palliative care for cancer patients. In palliative care, what we do is giving life to the days. It is not giving days to the life. We are not going to prolong the death. We are not going to extend the life the patient going to have. We just give life to the days where the patient is destined to live. In cancer, why are we worried about cancer? Cancer global incidence is 19.3 million. I'll give you a little bit of statistics. Though you feel it's boring, it is a bit important. Global cancer deaths about 10 million. This is 2020 Globocan statistics. It says 1 in 5 people develop cancer during their lifetime. And 1 in 8 men and 1 in 11 women die from cancer. And this is very important. 50 million people are living within 5 years of past cancer diagnosis. So just this crowd is very important to us. So the people who are living with cancer need lots of care so that we are destined to provide care for them. We'll just look at the cancer with the age. What type of cancers in which age is common? See, ALL. Everyone knows what is ALL, acute lymphoblastic leukemia, very common in childhood, right? And testicular cancer. Testicular cancer is very common in productive years of life from 20 to 50. Like breast cancer comes in more old age group, and the colon cancer is further age. Like this, prostate cancer is further age, further advanced age. And central nervous system cancer spread from child to the advanced age as well. So like this shows that every age you can get a cancer, but different prognosis in different type of cancer and the different person. If you as doctors, you would have experienced lots of cancer cases are diagnosed in advanced stages, stage 3 and 4. If the cancer is diagnosed at these stages, this is very common general statistics I'm giving. Their 5-year survival is usually less than 20%. This is some cancer specific survival may be varied even though they present in stage 4 and 3, but this is a general statistic just to give you an idea. 5-year survival will be less than 20. But if the cancer is diagnosed early, like in stage 1 and 2, they will survive 5 years, more than 80% of cases. Their 5-year survival will be more than 80%. Here, the lower stage cancers can be cured, right? We are looking at cure for these lower stage cancers. But here, in this 80% of cases, they will live very short period and they are approaching death. They need care more than the cure. So this is a big burden. More than 80% of the diagnosed cases need care. This is where we are now looking at what to do for this big group of patients. We look at this case we found in our wards. This is 45 years old bank manager. He was in middle class society, a father of 2 boys of 14 and 16 years. He presented with just 1 month history of right upper abdominal pain and loss of appetite. That is just 1 month. Before 1 month, he has been okay, just like any of us. His wife is not working. And examination revealed mild tenderness in the right hypochondrium and enlarged liver, otherwise normal. Investigations, basics normal. And this is his CT scan. You all can see the multiple liver metastasis in his CT scan. So, colonoscopy revealed a mass in the ascending colon. Yeah? Sorry? Am I audible? Well, yeah. Okay. And the biopsy reveals adenocarcinoma. And what is the diagnosis of this patient? He is carcinoma of colon, stage 4. Stage 4 colon cancer. It is metastatic colon cancer. As we all know, the 5-year survival is very low. We can say less than 20%. So this young bank manager is going to die in near future. So it is, that is the natural history in cancer. Yeah, if it present in advanced stage. Just look at this chart, graph. In the palliative care, we describe various illness trajectories. In this graph, it says the function in this line, and this is the time in the horizontal line. The function is at high level at start. It is at high level, and all of a sudden it starts to decline after the diagnosis of a incurable cancer. I'm talking about incurable cancer here because we all know palliative care is for incurable diseases. This may be not true for a cancer which is curable, like a small breast lump like cancer. But for an incurable cancer who need palliative care, so in palliative care, the cancer illness trajectory is described like this. They are at high functional states and they come down so rapidly. Within few years, they come down and death happens at the end. So, if such a person is diagnosed like this, what are the issues at the diagnosis? What are the issues with the patient and the family? This is a life-limiting illness diagnosed with a short history of sickness for just 1 month. Just imagine if it happened to your loved one. And it's a young family with 2 school kids. And he is the breadwinner. Wife is not working. And he has to undergo prolonged toxic treatment for cancer. And he need leave. He is working. And his finances will be affected with this. And there's another problem, as Dr. Ishani discussed earlier, like revealing diagnosis to relations and the workmates. Cancer usually carries a stigma in our society. Some people doesn't want to tell their relations or the workmates or tell anyone else that I'm having a cancer. So they are scared to say, like there's some sort of a stigma involved in diagnosis of cancer. This is very common. And also there is emotional issues in the family and the patients. There are so many emotional issues. You might in coming days these will be discussed in details. But we have to look at the emotions since the diagnosis of cancer. We will look at what are the emotions they're going to have. This is very important to know. At the diagnosis of not only cancer, any incurable illness diagnosis, first thing is the patient can get anger. They can get angry. Why it happened to us? What is this? So they feel angry. And also, next, they might feel denial. They might come to a psychological state of denial. Oh, no, that may be wrong. Maybe they have mixed up the samples. It's not my sample. I'm not having a cancer. Like that. So they can have denial sort of psychology. And then they can go into a state of bargaining. Like, I'm not going to have intravenous chemotherapy. Please give me tablets. I'm not going to have radiotherapy and things like that. They can go into a state of depression also. So you all know what is depression. So this is very common to go into a depression or low mood at the diagnosis of cancer. And finally, at a stage, they go into acceptance. that I'm having a cancer, I need to undergo treatment, and they with that emotion they develop hope that I will be cured and I'm going to get this and that and this, so that they think that they develop hope and they try to ask questions from the doctor about their cure and the treatment and all that. So that acceptance stage is the best stage for us. But they actually this emotional stages has been described. It doesn't mean that it comes in this sequence. This some people get more anger, more depression, or some people straight away come to acceptance stage. So they can straight away go into the acceptance stage. This changes. This can go up and down, and there may be variations in this. It doesn't happen in this sequence. But the most important thing for us is we all should know when a patient is diagnosed, they will go into various emotional stages like this. And when they say something, so we have to think that this person's psychological state is not normal. So we need to uh, address the psychological state properly. Then we will look at a cancer patient. What is their care trajectory? Usually, the cancer is cancer diagnosis and staging. Initially, the cancer diagnosed, and we do the cancer staging. And after that, there are two ways. Like one is going into treatment with intent of cure. That is what is happening if any patient diagnosed, go into the treatment with in cure intent treatment. If the cure intent treatment is not possible, they have to go into palliative treatment. So every patient should go into either of these two arms. And we look at what happened in the cure intent treatment arm. This is also important. When we treat a patient with intent of cure, patient might have a cancer-free survival. Lots of patients we have with cancer-free survival. And some of the patients will be managed with chronic co-intermittent disease. Just like in multiple myeloma patients, we give continuously drugs. Patient will be in slow remission state, sometimes little exacerbations. So whatever, the way they are having a small disease inside, but they leads a near normal life with the chronic disease inside. One good example is myeloma. So next stage is like these patients, like say multiple myeloma, go on like with some oral drugs, time to time drugs, and they at one stage they enter into a treatment failure level. Their treatment fails, so they can't. That's a problem. Then even the cancer-free survival patients who are surviving without cancer, cured cancer, they can also lead to a later on to a treatment failure stage by they getting a recurrence, or these even cancer-free patients or chronic cancer patients can later on get a second cancer. We see this many times in our patients. They can get a second cancer or a recurrence. Then it comes when they get a second cancer or recurrence. Again, it come back to the initial step, the diagnosis. If they get a recurrence, we need to diagnose stage and then go that. Again, treat as a new cancer, go into either treat cure arm or care arm. And here, treatment failure. What happened to them if the patient's treatment failed? Then they again go into the palliative treatment arm. And what happened to the palliative patients who are on palliative treatment at the end? That is the approach to the death. They so these are the patients who are incurable patients. The final endpoint is that. It is very important aspect in the cancer care. We need to look at this cancer-free survivors and cancer patients who are managing with a low volume disease. This yellow box area, we call it survivor, cancer survivor. This is care in this. These people also need a lot of care. We call it survivorship care. Survivorship care. So there are so many problems in these cancer survivors also. It is very important. Now we are looking at the palliative treatment arm, but if you are talking about cancer care in cancer patients, this survivorship care is also very important. So I am going to touch a little bit about this survivorship. The problems actually we will. I'm not going to talk about care, but the problems you should be able to have an insight on the problems they have to give a good care to these people. The survivorship cost, it will be time. So they with the cancer treatment and diagnosis, they need to take lot of leave from the work. And if their education, the education will be delayed due to the leave period they are spending on cancer treatment. They need lot of money. Their earnings will be impaired, and also there is lot of cost for the treatment and the care. That even though the government provide all the drugs and free hospital care, so they need to spend quite a lot in transport, and sometimes they need to have paid carers and their food, special foods and all that. So they need to spend a lot. Even everything is provided by the government through hospital and drugs. And there are problems with the carers. There are a lot of care issues. Paid carers are very expensive, and the family carers not only expensive. There are issues like everyone like to have a carer from their family, a loved one to be a carer for the patient. Every patient would love to have a family member carer. But if you talk about care is also, I don't know whether you have thought about this, we need to consider care as another patient, because care so many issues, so physical and psychological. You would have, but I don't know whether you have experienced being a carer to a family member. If anyone who has been a carer for the family member, you would have experienced this, how it is physically tedious and how it is emotionally tedious. And sometimes even you have to miss your job, sometimes financially also. Some people who are doing like temporary jobs, they need to quit the job. When the husband is sick, wife has to quit the job if they are doing a temporary job, if not a permanent job. They can't take it, so they have to quit the job. So there are so many issues. Care is another patient. We talk about the care issues in palliative care quite a lot. We need to care. Actually, the palliative team need to care not only the patient, but the carer also. Now you have to have new thoughts about this. Please take into your heads very carefully about the carer, the problems, and the need for the care to the carer. And there are relationship issues, interpersonal relationship issues. If I say one example, like when I met one African lady at one overseas, and she was telling a patient diagnosed with breast cancer on treatment that the patient's mother-in-law has advised his son not to sleep with this lady and sleep in another room, because this cancer will be infectious, and his son will also get this cancer if he sleep with the wife. So that type of foolish thoughts they have. So the patients might not volunteer to tell all this to us. If we develop a little bit of a communication rapport, only they will come out with these. These problems are even though we think they are very small, but it is very big when we consider the patient. If it happens to, just think that if it happens to us, what will happen? That in terms of that, we can develop a good empathy on our patients. Psychological issues, so they have to with the cancer diagnosis, they have to with the long term, live with long term side effects, fear of recurrences. There are social stigmas involved. So this, so when you talk about social stigma, they are here in Sri Lanka. The main issue is the giving the children to them to marriage. The breast cancer patients and the colon cancer patients, colorectal patients, people know that these cancers are coming in families, but they think that if the father or mother get the child, will definitely 100% risk of getting the cancer. It's not like that. No, it's very tiny, small risk increase if even if the father or mother get the cancer. Uh, uh, so that we need to explain properly. So I have so many occasions about marriages going to break because of the father mother diagnosed, arranged marriages going to break. So we have examples intervening with them and helping them to continue those. Mm. Okay. Components of care of cancer patients. There are so many. It is obviously a multidisciplinary approach in cancer management. And you need a very good clinical assessment. And we need to use investigations, so many investigations to be done in diagnosis and during treatment. And we should have, the patient should have good specific cancer treatment options. And also, we need to fulfill their information needs. There are so many things we need to tell them. And at the same time, they are very scared to ask us and very scared to talk to us. So that gap we need to break. So we need to develop good rapport through the communication skills. In palliative care, and not only palliative care, in cancer care, I think not only cancer care, in whole medical health care, this communication skill is very important. Um, and yeah, and here we need to facilitate decision making. Here we think like patients. Sometimes the patient come and say, no, I'm not going to take chemotherapy. I don't want radiotherapy, and I will sign. So what the doctor do is, so the patient write that I'm not going to take chemotherapy, and you sign and then discharge the patient. That's not the story. That should not be the story. We should have a proper, we should help them in decision making. Sometimes these patients refuse treatment just for little things. Sometimes just due to they are scared of the hair loss. Sometimes there was one patient who refused hair loss, treatment chemotherapy. Then she is not actually feared of the hair loss. She was feared of, she knew that the hair will regrow after the treatment, but she thinks that she cannot, that hair will not be able to color. So she can't color her hair black, the new hair she get after the cancer treatment. She thinks the hair dyes are toxic after the cancer treatment. So that type of tiny little, very unimportant, but it is very important. So it is life and death. Just due to that fact, she refused the cancer treatment. If we were not communicated properly, that patient will die. Now she's having a good cure, as well as her hair is looking nice with the hair dyes. So so those are, there are so many examples like that. Tiny little things we don't imagine what they are having in their minds, which we can come out through good communication only. And psychosocial issues are there, survivorship issues are there, as we discussed, and caregiver issues, as we discussed. And there comes the screening and the early detection. So this patient is a father of two boys. He's diagnosed with colon cancer. We know colon cancer can go in families, so early detection and screening for these kids are important. And the patient's family members, the brothers and sisters, it is important, early detection and screening. So these things are very important in even the patient is palliative or curative. Cancer palliative management, if we consider the palliative management for cancer, there are two arms of palliation: specific oncology palliation and general palliative care. Remember two things, like specific oncology palliation options are available. General palliative care is also needed for these cancer patients. What are the specific oncopalliative options? Like it is not only to cure the cancer, we use radiotherapy. We use radiotherapy to palliate the cancer. We use chemotherapy, palliative hormone therapy, biologicals, immunotherapy, small molecules. Everything can be used in palliative setting, but we need to use it in correct indications. And it is in this setting, I must say that it is very important, even though when a cancer patient is diagnosed, think that patient is having a metastatic cancer disease. And we know that patient is incurable. Still, it is important to get the help of oncologists. It is very important to refer to oncologists even though patient need palliative care. So the palliative specialist and the oncologist should work hand in hand to give proper palliative care to this patient. Cancer palliative patients also need care by a oncologist. It is a must. And the general palliative management, just same as for non-cancer. As Dr. Ishani described, the social, physiological, psychological things, and then symptom management and all that is just the same in cancer or non-cancer. And there are guidelines given by the National Cancer Comprehensive Network and standard of cancer palliative care to have the standard cancer palliative care. That all the cancer institutes should develop a process for integrating palliative care into cancer care as part of usual oncology care. Like as every oncology patient should have the option to obtain palliative care in every cancer institute. And also, all cancer patients should be screened for palliative care needs at the first visit and as appropriate in different intervals. All the patients should be screened for the palliative needs. And patients and families should be well informed on palliative care as an integral part of their cancer care. We have to inform the patient and the family that palliative care is also a part of cancer care. Considering these guidelines, we have to have educational programs to provide good knowledge, skills, and attitudes to the healthcare professionals. Today, we are doing something like that. Actually, just say this. It is not only knowledge and skills. Knowledge and skills, it's not only knowledge and skill. What is this? Attitudes. So this is very important in providing palliative care, the good attitudes. I think it is not only palliative care. If you look at your Hippocratic oath, which we all should obey, it is not only the palliative patient, every patient need to develop good attitude and this sympathy, empathy, and all these good attitudes to each and every patient, but it is more important in palliative care. Remember this attitude, we feel it is the bread and butter of healthcare workers. Even though however much knowledge and skill you have, if you don't have a good attitude, there won't be a good result of what you do. Remember that. I know you all will, be having good attitudes. A palliative care specialist and interdisciplinary team should be available in the cancer institutes, and quality of palliative care should be monitored continuously. Anything we can start, but whether it is happening correctly has to be monitored continuously. It is a must in administration. And we look at the summary now. Palliative care is always an active process. It is not passive process. active participation of complications and establishment of early management, active integration of psychological, spiritual aspects of patient care, active alignment of treatment and care plans with the patient's goals and values. That is called advanced care planning. So here it is, we decide on what to be done next, and until the patient's death, we need to decide, talk with the patient and the relatives and the care team and the healthcare professionals, come together and discuss what is the patient's next care plan. It is very important in palliative care setting, the advanced care planning. This helps in various ways. It will be discussed later on during this program. And we need to give active support to caregivers, active provision of grief and bereavement care. You know that bereavement care and the grief care is also a part and parcel of palliative care. Advanced care planning is very important. Thank you.